Functional Neurological Disorder, a case study. Case summary. A 50-year-old female was brought in by ambulance to the emergency department with vague lower limb neurosymptoms. The patient was found by her sister on the floor of their living room, unable to get up. The patient was shortly after arrival transferred from the emergency department to the ward. MRI and CT scans showed no abnormalities. The patient had not previously experienced an episode like this before, although had progressive lower limb weakness over the past 6 weeks. Subjective assessment. The patient's past medical history included depression and anxiety, as well as being a current smoker. Their medication history included Prozac and Nurofen. The patient's social history was that she was recently divorced in the last 12 months and now currently living with her sister in a single-story house with no steps. The patient is nil gait aid at baseline mobility, although has been using crutches over the past 6 weeks to help mobilize. The patient previously worked as a nurse, although quit recently due to a bullying incident at work, in which she is now currently involved in a workers' compensation claim. The subjective assessment revealed that the patient had been experiencing progressive weakness in both legs within the past 6 weeks, beginning shortly after the bullying incident. The patient was unable to feel their legs, reporting tripping on her own feet on several occasions, currently unable to move her legs actively. Objective assessment. The neuroexamination of the patient showed no abnormalities in the upper limb, although the lower limb the patient was unable to move their toes, either no feeling or altered feeling with light touch sensation tests throughout both limbs, and a 5 out of 10 on a proprioception test, and no response to various reflex tests. In order to mobilize in bed, the patient had to physically move her legs with her hands in order to sit on the edge of the bed. In sitting over the edge of the bed position, the patient was unable to achieve 1 full rep of knee extension, hip flexion, or calf raises, although occasionally there were small amounts of muscle activation. A sit to stand with the Steady with 2 times assist resulted in the patient using her upper body to pull and hold herself up, with her legs giving away from underneath her body. Clinical impression. With my current knowledge, plus discussion with the neurosurgeon looking after the patient and discussion with the physiotherapy team and my supervisor, we discussed the possibility of functional neurological disorder, as the patient was meeting its criteria. The next day, the neuro team diagnosed the patient with FND. Functional neurological disorder, FND. FND is a condition in which the patients experience neurological symptoms, although they are not caused by a specific structural disease of the nervous system. To date, the exact cause remains unknown, although factors such as stress, other neurological conditions, chronic pain, and fatigue have been linked to an increased susceptibility. Signs and symptoms of FND include motor dysfunction, such as muscle weakness and movement disorders, sensory dysfunction, such as altered sensation, and finally episodes of altered awareness, such as dissociative seizures, blackouts, and faints. Physiotherapy intervention. Research in this area still lacks evidence, although physiotherapy's role on focusing on automatic movements have been shown to have positive effects. The 2 main therapies for FND is cognitive behavioral therapy, CBT, and neurologic music therapy, NMT. CBT is psychosocial intervention that aims to challenge and change unhelpful cognitive distortions and behaviors, improving emotional regulation and the development of personal coping strategies that target solving current problems. NMT is a therapeutic use of music applied to sensory, speech and language, cognitive, and motor dysfunctions after a neurologic event or diagnosis. All 3 of these methods have promising results in treatment, raising the question around the use of a combination of the 3 therapies for treatment of FND. Bed exercises were given so that the patient could continue to exercise when physio was not available. 2 times assist sit to stand with Steady was used to work on automatic movements, to help and work holistically with the lower limb. The Steady was also used for transfers to the physio gym, in which exercises such as ring toss and sit to stands, both with reaching to targets and across the opposite leg, to help increase distraction and muscle activation. After researching regarding musical therapy and cognitive behavioral therapy, I decided to try and use music to aid as both a distraction and a positive mood booster. I completed the same exercises as before, except now with the use of music. Over a period of 3 days and multiple sessions, there was an increase in lower limb function when exercises were aided with music. The patient was able to achieve 5 to 7 reps of knee extension, hip flexion, and calf raises on both legs in sitting over the edge of bed, showing an improvement from the original 1 out of 5 and 2 out of 5 grade strength, all the way now to a 3 out of 5 grade strength for both legs. Discussion. Exercise in combination with music in this particular case led to drastic improvement in overall muscle function, although left sensation relatively unchanged, with the patient still having altered sensation throughout both legs. Treatment would have been continued, although the patient was transferred to a hospital closer to home, in which she would participate with a multidisciplinary team to treat the condition. There is limited research around FND and physiotherapy's role in treatment. Further research would enable improved treatment of FND patients. Further research should also be conducted around the use of music in combination with exercise.